Today we are going to walk through a canine spay, specifically an open ovariohysterectomy, or OVH. An ovariohysterectomy removes both ovaries, both uterine horns, and most of the uterine body. This differs from an ovarectomy, or OV, where only the ovaries are removed. Both procedures provide permanent sterilization when performed correctly. Removal of functional ovarian tissue prevents future estrous cycles and pregnancy, and eliminates ovarian disease. It also essentially prevents pyometra when the ovaries and hormonally responsive uterine tissue are appropriately removed. OVH additionally removes most of the uterus, preventing most primary uterine disease. Gonadectomy before repeated estrous cycles has also been associated with a lower incidence of mammary neoplasia, although the magnitude of that benefit and ideal age of sterilization vary with breed, body size, and individual risk. Before surgery, perform a complete physical examination and appropriate pre-anesthetic testing. One example anesthetic protocol for a healthy dog is methadone at approximately 0.2 to 0.4 mg per kilogram IV for mu-opioid receptor-mediated analgesia, sometimes combined with dexmedetomidine at approximately 3 to 7 micrograms per kilogram IM, an alpha-2 adrenergic agonist that decreases norepinephrine release and produces sedation and analgesia. Propofol at approximately 2 to 6 mg per kilogram IV, titrated to effect, potentiates GABA receptors for induction before endotracheal intubation and inhalant anesthesia such as isoflurane. Exact protocols must be adjusted for the individual patient. Place the dog in dorsal recumbency and perform a wide aseptic abdominal preparation. Common instruments include a number 3 scalpel handle with a number 10 or 15 blade, Adson Brown or DeBakey tissue forceps, Metzenbaum scissors, Mayo scissors, Mosquito, Kelly, or Cryle hemostats, Rochester Carmalt forceps for vascular pedicles, a Snook Spay hook, and Mayo Hagar or Olson Hagar needle holders. A Balfour retractor can be useful when greater abdominal exposure is needed. The approach is a ventral midline celiotomy. In the dog, the incision is generally positioned caudal to the umbilicus and extended far enough caudally to safely exteriorize the reproductive tract. Incise through the skin and subcutaneous tissue until the linea alba is clearly identified. Elevate the linea alba before entering the abdomen to reduce the risk of damaging underlying abdominal organs. Locate a uterine horn digitally or with a Snook Spay hook. The hook should be swept gently along the internal abdominal wall rather than blindly pass through abdominal viscera. Confirm that the tissue obtained is actually uterine horn before applying traction. Follow the horn cranially toward the ovary. The canine ovaries are located dorsally immediately caudal to the kidneys and are partially enclosed within ovarian bursae. The proper ligament connects the ovary to the cranial-uterine horn, while the suspensory ligament extends craniodorsally from the ovary toward the body wall near the last rib. The ovarian vascular pedicle lies primarily within the mesovarium. The ovarian arteries originate directly from the abdominal aorta caudal to the renal arteries. Venous drainage is asymmetric. The right ovarian vein drains into the caudal vena cava, while the left ovarian vein drains into the left renal vein. Apply controlled caudal and medial traction and carefully stretch or digitally break down the suspensory ligament as needed to exteriorize the ovary. Do not blindly tear tissue close to the ovarian vessels. Create an avascular window in the mesovarium caudal to the ovarian vascular pedicle. A common method is the 3-clamp technique using Rochester Carmalt forceps. 3 clamps are placed across the ovarian pedicle. The most proximal clamp creates a crush groove where the first ligature can be seated. Synthetic absorbable sutures such as polydioxanone, or PDS, or polygalactin 910 can be used. Approximately 2 to 0 or 3 to 0 may be appropriate in small dogs, while 0 or larger suture may be required for a large mature dog. Suture size should be selected according to the diameter and vascularity of the pedicle rather than using one size for every patient. A circumferential ligature is commonly placed in the proximal crush groove. In larger pedicles, a second ligature can be added, such as a transfixing ligature distal to the first but still proximal to the transection site. A miller's knot is especially useful on bulky vascular pedicles because its double encirclement creates substantial friction and resistance to loosening. Transect the ovarian pedicle distal to the ligatures while maintaining control of the ovary. Before allowing the pedicle to return to the abdomen, slowly release the forceps and directly inspect it for hemorrhage. Repeat the procedure on the opposite ovary. Follow both uterine horns caudally toward the uterine body. The broad ligament consists of the mesovarium, mesosalpinx, and mesometrium. Thin, relatively avascular portions can often be bluntly divided in a young dog, but visible vessels should be individually ligated or appropriately sealed. The uterine arteries run cranially along each side of the uterus within the mesometrium and anastomose with branches of the ovarian arteries. Exteriorize the uterine body sufficiently to clearly identify these vessels. For a traditional OVH, place clamps across the uterine body cranial to the cervix. In all but very small uteri, the uterine vessels can be secured with transfixing ligatures, followed by an additional circumferential ligature around the uterine body. A miller's knot can again be used for the circumferential ligature. Be careful not to incorporate a ureter into the uterine ligature. The ureters travel retroperitoneally toward the urinary bladder, and excessive tissue capture can result in ureteral obstruction. Transect the uterine body cranial to the secured ligatures and remove the reproductive tract. Inspect the specimen and confirm that both ovaries, both uterine horns, and the expected uterine tissue have been removed. Before abdominal closure, inspect both ovarian pedicles, the broad ligament, and the uterine stump for bleeding. The major acute surgical complication veterinarians and veterinary students should be prepared for is hemorrhage, particularly from an ovarian vascular pedicle after a ligature slips, loosens, or was improperly positioned. A bleeding pedicle can retract dorsally into the abdomen and become difficult to retrieve. Postoperatively, tachycardia, pale mucous membranes, weak pulses, hypotension, abdominal distension, decreasing Paxil volume, weakness, or collapse should raise concern for internal hemorrhage. Other important complications include seroma formation, incisional infection, self-trauma, abdominal wall dehiscence, ovarian remnant syndrome, stump pyometra, and inadvertent ureteral ligation. Ovarian remnant syndrome occurs when functional ovarian tissue remains and may later produce vulvar swelling, behavioral estrus, vaginal discharge, or attraction of male dogs. Ureteral obstruction can cause hydroureter, hydronephrosis, renal damage, and potentially azotemia. For abdominal closure, the linea alba or external rectus sheath is the primary strength-holding layer and can be closed with an appropriate absorbable suture such as PDS using a simple continuous or simple interrupted pattern. Close the subcutaneous layer with approximately 3 to 0 absorbable suture in a simple continuous pattern to reduce dead space. The skin can be closed with a buried continuous intradermal pattern using approximately 3 to 0 or 4 to 0 absorbable monofilament, or externally with interrupted nylon, polypropylene, or skin staples. Postoperative analgesia commonly includes an NSAID when renal perfusion, hydration, gastrointestinal status, and other contraindications have been evaluated. Carprofen can be administered at approximately 4.4 mg per kilogram every 24 hours or 2.2 mg per kilogram every 12 hours. It preferentially inhibits cyclooxygenase activity, decreasing prostaglandin production and inflammatory pain. Local anesthetics such as bupivacaine can also provide analgesia by blocking voltage-gated sodium channels and preventing nociceptive nerve conduction. Most healthy dogs undergoing uncomplicated elective OVH can go home the same day once awake, normothermic, ambulatory, cardiovascularly stable, and adequately analgesed. Activity is generally restricted for approximately 10 to 14 days, with prevention of running, jumping, swimming, rough play, and licking or chewing the incision. The most important technical principles are accurate identification of reproductive anatomy, atraumatic tissue handling, secure vascular ligation, complete ovarian removal, careful inspection for hemorrhage, and a mechanically secure abdominal wall closure. If you have topics you would like to suggest, Reach out to dogtoursgame@gmail.com.